Hey guys, my name is Mike Abood. I'm one of the Hammer residents, and today we're going to talk about the superficial cervical plexus block. So let me introduce our patient, Mr. MM. He came into MGH in the fast track section a couple months ago. He was 54 and had no significant past medical history. He presented with right shoulder and right arm pain after a fall while skiing. The story he told was that he was going down a slope and had a fall directly onto that right shoulder. Did hit his head, but had no loss of consciousness, confusion, or any other concerns for a head or neck injury. However, at the scene, he had immediate pain and inability to move that right arm, secondary to pain in that right shoulder and collarbone area. He had no neurologic symptoms, including numbness or tingling, and was able to wiggle his fingers. Furthermore, he had no other injuries, including or other symptoms, including shortness of breath, chest pain, back, neck pain, etc. So this is a representative picture of a patient with a similar injury to MM. As you can see, he had a pretty significant deformity of the right clavicle. And upon presentation, if you look at his vital signs there, basically within normal limits, maybe a little hypertensive due to the pain. So this is MM's Xray. As you can see, he had a pretty significant fracture of that right clavicle, no other associated injuries. But they read this as a comminuted fracture of the midclavicular shaft with inferior displacement of the distal fracture fragment. So as you can guess, this was a pretty painful injury. The patient was initially given oral oxycodone, but he was still in moderate pain after administration of the oral pain medication. In speaking with the patient, he expressed a desire for pain control without becoming sleepy, considering he wanted to drive home and really didn't have a good reaction to narcotics. So we spoke with him about a different approach, a superficial cervical plexus block that could be given in order to get good analgesia without the systemic effects of a narcotic. The patient was consented for this block with 0.5% bupivacaine. So this is a nice neck dissection done by Nysora. Shows the anatomy surrounding the superficial cervical plexus. As you can see, these are the nerves of the superficial cervical plexus coming from behind the sternocleidomastoid muscle in the lateral neck. This is the sternocleidomastoid coming this way, and as you can see, the nerves are closely associated with the jugular veins. This is the external jugular vein. This is the dermatomal distribution of the superficial cervical plexus, which comes from C2, C3, and C4. As you can see, it covers a large portion of the lateral neck, coming all the way down to the clavicle out laterally. It also comes up and catches the inferior portion of the ear and actually can be used for repairs of lacerations of the lobule of the ear. So in terms of the indications for this kind of block, obviously probably the most common one is pain control for clavicular fractures. Also a common one would be central line placement, particularly internal jugular vein cannulation. Furthermore, patients who present with abscesses or other soft tissue deformities requiring procedure over the lateral neck, shoulder, or lower ear can get a superficial cervical plexus block. And a final indication is carotid endarterectomy, which is obviously not something that we would do very often in the emergency department. So in terms of the positioning of the probe, as you can see here, we use a linear probe placed over the lateral portion of the neck. It's positioned horizontally, about halfway between the mastoid process and the clavicular head of the sternocleidomastoid muscle. And this placement will give you a view similar to this. As you can see here, this is the left side of the neck. This will be medial, and this side over here is lateral. And as you can see, this is the sternocleidomastoid muscle superficially. Underneath, more deep to those other structures are the scalene muscles, and there's a fascial plane lying in between those two muscle bellies where the superficial cervical plexus lives. They're often difficult to see, these small nerves, but you can rest assured they live in this area. Something important to notice is that the phrenic nerve also lives in this area, a little deeper than the superficial cervical plexus, but just something to note when you do this procedure. So this was the initial picture that we had of our patient. As you can see, this is the opposite side of the body on the right side relative to the previous picture. And just to reiterate, the sternocleidomastoid lies superficially, the scalene muscles lie deep, and this fascial plane here is where the superficial cervical plexus lives. In this video, you can see our needle coming in laterally into this fascial plane, just underneath the sternocleidomastoid muscle. And we bring in this needle and approach the area of the superficial cervical plexus in order to inject the bupivacaine. Now, as you can see here, the needle, again, is coming in laterally to medially, and there's injection of bupivacaine in this area here, which is a little superficial to the fascial plane where the superficial cervical plexus lives. That being said, this is a plexus block, so close is often close enough, and you'll usually get pretty good pain control with an injection in this area. However, in order to ensure that we had good pain relief, the needle was advanced a little bit further, and as you can see here, bupivacaine was injected right into that fascial plane, ensuring good anesthesia for our patient. And in fact, after this injection, maybe about 20 minutes later, I went back and checked on him and actually was able to mash on that clavicle and got pretty significant crepitus. And he didn't even realize that I was pushing on his clavicle. So clearly he had really good pain relief. So there are some complications that have to be kept in mind when you do a superficial cervical plexus block. However, it is a relatively low-risk procedure. Anesthetic toxicity is something we're always concerned about when we do nerve blocks or other kinds of anesthetic injections. However, this is a very low volume injection, typically less than 10 cc's. And in this case, we used maybe 4 or 5 cc's of bupivacaine. So this is well below the toxic dose of either bupivacaine or lidocaine. Now, if you do miss the area, you can have some more significant complications. Now, if you go a little too deep of the superficial cervical plexus or inject a large amount of anesthetic, you can get phrenic nerve paralysis, resulting in a paralyzed hemidiaphragm. Now, this would be particularly concerning in a patient who had a respiratory compromise, and so respiratory issues would be a relative contraindication for this procedure. That being said, phrenic nerve paralysis is a relatively rare complication. There's nothing really to lose sleep over, just something to keep in the back of your mind. If you go too inferior within the neck, you can actually get a brachial plexus block, and this would be a rather inelegant complication considering you're going to numb up the person's arm and not actually give them good pain control for their clavicular fracture. And obviously, anytime you're in the lateral neck, missing medially is not a good thing to do considering the carotid artery and jugular veins live in that area, and large vessel injuries can result in significant morbidity or mortality. All right, and these are our citations. We used NYSORA, which had a lot of great things about any kind of plexus block. Also, USRA, as well as our website at the bottom. So everybody come and visit.